Okay, so we're going to be talking about understanding pain and the difference that it makes to physiotherapy. Would you like to teach me? Tell me all sorts of things?
Yeah, I think what we wanted to do was have a little think about making pain less painful and making it easier to understand, because I think as an MSK physio particularly, it may be one of those areas that when we were training we found quite dull, quite dry, very theoretical, very molecular. But what we need to do is try and understand it from a clinical point of view and really understand what our patients are going through and some of the clinical perspectives of the pain processes, so that we can understand how and why we need to treat patients maybe a little bit differently. So that's the idea of starting to have a think about some of these pain processes. So really, for me, there's a few key things that we need to think about that we'll have a little chat. And the first one is our own starting point, really, and what our beliefs are about pain and what our understanding is. Is it something that we've naturally shied away from because we didn't understand it or it was a bit dry? Is it something that we've not really thought about how we interpret that in terms of our assessment processes? Do we fully engage with it? So what's our starting point in how we understand pain and interpret it and discuss it with patients? Do we actually talk to them about it? And if not, why not? So what's our understanding, what's our starting point really?
Okay, so you mean as someone who's understanding pain and learning about pain, but do you also mean it's important for me as a physio to know what my worries are about pain and what I think that means, so that it doesn't have a negative impact on patient assessment?
Absolutely, because it may be if you're the type of person who tends to catastrophise yourself when you've got something wrong with you, are you then going to be more anxious with your patient about certain things and very quick to pick up on things and be quite anxious and concerned about it? Or are you the sort of person that maybe will not really want to know that much detail about it? And again, do you then automatically assume your patient doesn't want to know that much? So again, it's all of those things really that will have an impact. So thinking about our starting point and really reflecting on that's important. The second one is really thinking about what information goes into our system. Something has to come out as a result. So we need to think about normal and abnormal pain processes, what the nervous system should normally do and relay to our central nervous system, and how the brain then processes that. And being able to do that, we need to understand a little bit about normal anatomy and function of the nerve to understand what happens when it goes wrong and what impact that has on how we interpret it as well. So we need to have a little bit of understanding of that dry, boring stuff, but if we do it from a more clinical perspective, it has more application to us. So that once we understand that, we can understand what a patient is doing or saying or how they're behaving that may be abnormal, maybe a little bit more maladaptive, and to figure out where in this process that maladaptation, is it one place or is it more than one place, so we can understand where we've got to target. And a nice way to think about that is this Gifford model, where he talks about an input and a processing and an output response. So if we've got normal information going in about an injury, a sprained ankle, an OA knee, that the brain is then interpreting that information from the periphery. It's going to do things as a result of that information going in. But what we want to know is when that information and how that nerve is functioning, behaving, is telling the brain wrong information, the brain's got faulty information to make a decision on, so then the output response isn't going to be appropriate, or it thinks it's helping us when actually it can be perpetuating this cycle. So it's a nice simple model to think about the information going in, how we're interpreting it, and what our brain is making us do as a response.
That's really interesting. It does look very different from what I was taught about pain when I was at university. Can you tell me a little bit about how does that change what we do as physiotherapists? How does that change our practice?
I think what's been nice with some students, undergraduate and postgraduate, that have gone through different modules, they've actually started to challenge how they think about pain now. So whereas before they might have been very tissue-based, thought about very much diagnostic labels, they're actually challenging their own thought process and understanding about where in these systems things are happening. So they're able to target their treatments much more efficiently and effectively.
Okay.
They might be doing the similar things as what they did before, but their understanding's changed, and how they discuss and talk to patients about these processes changed. So they're engaging more with the patients about it as well.
Okay.
So it can be really quite positive in terms of a response. So this sort of summarises that. We're thinking more about the brain particularly, and again as MSK physios that's something we probably wouldn't have thought about before as much, but really about how that brain's reacting to the information coming in. So there are people such as Butler and Mosley and Tracy that have come up with terms such as a neuromatrix, a cerebral signature, that start to make us think about how we process and how we respond to information going in.
Okay, what do you mean by cerebral signature? I don't know what that is.
So these are terms that these authors have come up to explain about how every individual will have their own little map or processing system as a response. So it's a little bit like if you're playing on a pinball machine and you pull the pinball, it pings round the board.
Okay.
So every time you pull that, it'll go a different route.
Okay.
So it's a bit like we'll all have our own little...
All have our own pinball machine.
Absolutely, and how we process that information. And that's what makes how we approach managing pain needing to be unique for each individual, really. And if we think about that again, we can start to pick up what are some of the other clues, what are some of the things that a patient's saying, how they're behaving, what are their threats, what are their anxieties that's making them have that pinball behave a certain way. And then what we need to think about then ultimately is what can we do about it? Is it that we have to, where in that 3-stage process do we think we need to focus our energies to start with? Because it may be in a few areas. Is it that we want to alter the dysfunction first? Is it in how we try and engage the patient and their understanding? So that might be using metaphors or mantras to try and get them to understand those pain processes in a non-threatening, non-fearful way. And then we might be using certain treatment options. So it may be that we actually become more justified in the use of manual therapy for patients that have got chronic pain because we want to alter their input system.
Okay.
We want nice information going in to help them then exercise and move differently.
Okay.
So it's how we start to deconstruct and challenge that pinball machine and the information that's going in.
I think it's really interesting that you're talking about patient education, but it's not. It's a very different sort of patient education, and that might actually include hands-on treatment.
Absolutely.
In order to help somebody to understand their body and their movement better.
Absolutely.
Lovely.
And how again we come back to our own interpretation of what pain is and how we do that. That comes across in that as well. So I guess from a clinical point of view, the challenge is to move away from a medical model about trying to find a structure, about treating a diagnostic label. It's not about treating whiplash or tennis elbow or something like that. It's about understanding the appropriate pain process or maladaptive pain process that's happening, why a patient is behaving or managing that a certain way, so we can understand how we can then try and affect that behaviour and that pattern to change those patterns of behaviour as well. And that might be through various means, so that we have a positive influence and hopefully prevent those boomerang patients that then end up in a perpetual pain cycle that keep coming back into the systems.
Okay, that's really helpful. Thank you very much. That's really interesting.
You're very welcome.
Thank you.